This talk is meant for nursing staff and will cover agitation, anxiety, and delirium in hospice patients. As an introduction, agitation is usually going to be a multifactorial process with a lot of different causes. After reviewing some articles, there's really no good consensus for best practices in medication treatment of the agitated patient. And treatment is going to vary depending on the care setting and the POA wishes of the patient. Also, the goals of this talk are really to evaluate agitated patients and to discuss the different treatment options. The primary groups of patients that we would encounter in a hospice situation would be those that might have an acute new medical condition. They could have terminal restlessness in an actively dying patient with really any terminal diagnosis, be it cancer or dementia. And you could have a dementia patient with just escalating symptoms as their disease progresses. The last group of patients would be patients with pre-existing psychiatric diseases such as certain bipolar disorder, schizophrenia, substance abuse disorders with escalating symptoms as disease progresses. Some basic definitions that need to be discussed. Anxiety, pretty simple to understand. It's a fear of something. Whether that be future symptoms that the patient is anticipating or potentially just anxiety about their impending death now that they are on hospice. Agitation is usually a generalized term, has kind of a continuum of symptoms, but it basically boils down to the inability to calm oneself and can be manifested as wandering, repetitive speech, with certain mannerisms or just generalized restlessness. Aggression would be specifically an agitated patient with physical and or verbal actions that are disruptive or harmful to themselves or others. So that's an important thing to talk about when you're specifically looking at aggression. Delirium is usually a subacute onset or fluctuating attention, awareness, and cognitive function due to an acute medical condition. Specific to psychoses symptoms, talk about delusions, which is really a thought process that is made up or not real, versus hallucinations, which is either visual or auditory symptom that is made up or not real. So one is a thought process, the other is the patient stating they either see or hear something that's not real. When discussing the etiology and pathophysiology of agitation, there are really specific brain function changes that occur in agitation, but it's a very complex neuroanatomical, neurophysiologic, and neurotransmitter pathways that are involved, and we don't really need to cover that here. Things to think about in the agitated patient are looking for reversible causes of agitation. That might be an acute infection like a UTI or developing pneumonia. Hypoxia with low O2 sats can make people confused and agitated. Hypoglycemia is an easily reversible cause of agitation, so a quick glucometer check would be in order. Maybe they have an acute pain that they aren't able to verbalize that's causing them to be agitated. The agitation could be from a medication side effect. There are a lot of anticholinergic medications like doxepin, amitriptyline, oxybutynin, and even atropine, which we might be using for secretions that can cause acute agitation in some patients. Is there illicit drug use in the patient that's causing them to be agitated and you just don't know that that's going on? Maybe there's sleep-wake cycle disturbances. Maybe they haven't slept more than 30 minutes at a time for several days and that's causing them to be agitated. And finally, acute urine retention or severe constipation. If you treat those symptoms, agitation can greatly improve. Some of the medically treatable causes of agitation. Someone could have undiagnosed focal seizures or be having a post-ictal state after a generalized seizure, and that's making them agitated, and adjusting medications could improve that. They could have a undiagnosed mood disorder, be it chronic anxiety disorder, depression, or a bipolar disorder. Next would be personality disorders. They may have had a personality trait that they can no longer self-control due to disease progression, which is usually a frontal lobe disinhibition. So in that category, you could think of the kind of in-your-face kind of patient that can no longer control that last bit of anger, and so they become agitated. Psychotic diseases, specific types of bipolar disorder and schizophrenia, they may have variable intake of their chronic medications at end of life, and that's causing them to have increased agitation. And then neurodegenerative diseases like vascular dementia, Alzheimer's dementia, Lewy body dementia with behavioral symptoms. Those patients can get some agitation as their disease progresses. The evaluation of the agitated patients, just some general considerations. First and foremost, keep yourself safe. There's been numerous events where people can have agitation and be seriously injured by the patient as a caregiver or as the nurse, so be careful. Is there a substance abuse history with either the patient or someone in the household that you need to know about? Is there a history of recent trauma or falls with a head strike and maybe someone on blood thinners that's developed a subdural hematoma and that's causing them to be confused? Do a medication review. Has there been any recent medication addition, subtractions, or dose changes? For example, have we recently stopped a cholinesterase inhibitor like donepezil, and that's caused them to have some increased agitation? And then just a medication inventory. Has there been any willful or accidental overdosing or underdosing of prescribed medications that could be causing them to be agitated? Looking for acute physical changes is important. Is there slurred speech, lateralizing weakness, pupillary changes, changes in vitals, a fever, hypoxia, new signs of pain or jaundice, that type of thing? If you are suspecting maybe an acute stroke, having a discussion with the POA and family about how aggressive they want to be with care is important. Whether they want to revoke and go back to the ER, etc. Hypoglycemia, easily be able to do an AccuCheck to determine if that's causing the problem, doing O2 sats to rule out hypoxia, or if it's found to add oxygen if needed. Is there signs and symptoms of a UTI or pneumonia? Most of these we're going to try to empirically treat with antibiotics instead of doing aggressive workups, because we would end up at the same decision later on. And acute urine retention, assessing the abdomen, asking for a single in and out straight cath order, both male and female, for neurogenic bladder or acute bladder obstruction. Assessing the abdomen for signs of constipation. When was their last BM? And if there's been no recent BM, a rectal exam to see if they might be impacted. And is there new pain issues? Are they uncomfortable up in a wheelchair? Do they need a different chair or body repositioning? Could there be new wounds on their bottom? Possible fractures from a fall that was maybe unwitnessed. All of these things should be kind of assessed for causes of agitation. And then try to classify the mental status findings that you're looking at. Is the anxiety just kind of a generalized restlessness, or is it developed into more aggressive behaviors with maybe poor impulse control and the potential for harm to others? And then the psychotic features that we've talked about, if those are present, that puts you down a whole other avenue of treatment options if there's delusions or hallucinations present. And then the level of consciousness and verbal interaction. If someone's normally very talkative and now all of a sudden they're not speaking at all, then obviously there's something pretty serious going on that needs to be evaluated. When discussing family and caregiver education and expectations, I think just like in pain control issues, understanding the expectations of family and caregivers is important. Knowing where they are in the thought process for the dying patient. So you're going to discuss whether you work this up or you treat to just comfort and safety in the home. Education for both family and caregivers is important, and understanding what the family and caregiver breaking point is to providing care. If they're already at their wit's end, there's no reason to think that changing medications is going to help them. They may just need a change in place of care. And if that's needed, then that takes time to bring that into effect. So think about a change in place of care. And just talking about with the caregivers and family steps in the treatment plan, that you're going to look for reversible causes. Is there a non-pharmacologic treatment that can be looked at that may help the patient be more calm? And then the medication treatment options, discussing the pros and cons of different medications, potential outcomes, even if we do start the medications, and the potential side effects. Further discussion about family and caregiver education and expectations is to look at misconceptions. It's not always possible to get an agitated patient under control without some level of sedation, and the potential for a more rapid decline in their social interactions and decline in oral and food and fluid intake is definitely possible once you start to treat the agitated patient. And then if it looks like this is terminal restlessness, just like pain, we should be treating that and explaining that to family, that this is to keep the patient comfortable and help with family coping with the dying process. Simple non-pharmacological options to treat agitation, treating reversible causes as able, whether it's an infection or medication, etc. Distraction techniques, obviously this is based on maybe the patient's prior career. If they were used to being active all the time, they may get more active and wander more than someone who was used to being more sedentary. Environmental factors, can you get them into a more quiet environment? Maybe they have an agitated roommate that is causing them to be agitated, and just switching rooms could be the answer. Music or pet therapy obviously could be used in someone who is anxious and needs to be kind of redirected for a time. Obviously, restraints are not an option in hospice, at least physical restraints. Some people would look at the medications we use as somewhat chemical restraints, but again, they're used for patient comfort to help them from harming themselves or others. Just like with pain medications, the medication treatment options for the agitated patient are going to have several things that we're going to be looking at. The potency and side effect profiles of some of these medications are actually beneficial for the patient. If they're somewhat sedating, that can actually help if someone's really agitated and not sleeping. We need to make sure they're on the formulary and are covered. And then the root of medication is the patient already to the point they can't take pills and need liquid medications, and at least a couple of these medications, at least Haldol, comes in a topical gel that can be used. So if patients just refuse all other medications. Dosing and frequency, very similar to pain medications. The psychiatric medications can be started out as just a PRN dosing versus scheduled, and really that depends on the place of care. If someone's using a PRN more than 4 to 6 times a day, then we really need to be scheduling that or looking at increasing the dose so that it will last longer for them. And just like with pain medications, I think any medication we're giving the patient, the patient, family, and caregiver, if they're having to give something more than every 4 hours, at least not up until the very end of life, it's just too much of a burden. So we need to be looking at how to adjust the medication so that they don't have to give it so frequently. And then follow up on the efficacy and availability. Even though we put in an order for something, did it get delivered, and how has it been as far as being effective? And are they giving it as we requested? And then titration of the psychiatric medications can be made fairly rapidly depending on the severity of the symptoms the patient's having. So looking at the different medication classes that we have to treat the agitated patient, one of the most, I would say, benign medications we could use to treat the agitated patient is treating with antidepressants. They have a lot of positive effects on anxiety symptoms, and there are a lot less side effects with antidepressants. There's really too many antidepressants to list here, but a lot of times either citalopram or escitalopram are frequently used as first-line therapy for depression and anxiety, and even a dementia patient with these symptoms too. The second medication class, anxiolytics, this is really not the first choice if the patient has psychotic symptoms. So a lot of the facilities will just ask straight for lorazepam and they want to snow somebody with that, but we need to kind of go through the list and pick something that might be better for the patient. The ones that we typically see, hydroxyzine or Atarax, this has a lot of anticholinergic side effects, and we really try to avoid this medication unless it's for itching or something like that. It's on what's called the Beers list, which is a list of medications that are thought to be relatively contraindicated in the elderly due to side effect profiles. Buspirone or Buspar comes in 5, 7.5, 10, 15, and 30 milligram tabs, and is a really good first-line treatment for people with just generalized anxiety due to a favorable side effect profile. Lorazepam, which is one of our go-to medications, or Ativan, this can cause paradoxical agitation and is not always a great first choice for agitation unless there's really some pre-existing anxiety disorder, or of course we can use it in patients with terminal restlessness. It comes in 0.5, 1, and 2 milligram tabs, and in a 2 milligram per cc oral solution. These other benzodiazepines, alprazolam, clonazepam, diazepam, are all formulary, but we're not commonly using those due to the pharmacokinetic profiles that make them more unfavorable in the elderly. And then last is trazodone or Desaril. That comes in 50, 100, 150, and 300 milligram tabs. Used a lot, obviously, for patients who have insomnia and given usually at HS. Continuing on with the anxiolytics, divalproex or Depakote, we use this quite a bit as well. It's converted to valproic acid in the body and is roughly a 1-to-1 equivalent. So if you're talking about a certain dose of valproic acid or Depakine, you're also really the same dose of divalproic or Depakote. And that comes in 125, 250, and 500 milligram delayed release tabs, and 250 and 500 milligram extended release tabs. And then what we use a lot is the 125 milligram delayed release sprinkles that come in a capsule that can be opened and put in food. The valproic acid or depakine does come by itself, 250 milligram capsules, but this is the liquid formulation that we typically go for if the Depakote is working for someone, and that comes in 250 milligram per 5 cc oral solution. And then this last one I put in is gabapentin. It's something that we use a lot as well for neuropathic pain, but it also has some anxiolytic properties and a fairly good side effect profile. Comes in 100s, 300s, 400 milligram capsules, and then 600 and 800 milligram tabs, 250 milligram per 5 cc oral solution. It does have some sedating effects, so if possible, it should be dosed in the evening unless someone's using it for neuropathic pain during the day. Then we move on to the class of antipsychotics. This is going to be our first choice whenever there's psychotic symptoms such as delusions or hallucinations are present. Haloperidol or Haldol. I noted here that this can be used for nausea as well, so just because you see this on someone's med list, don't assume that it's for agitation. It could have been that they are using it for nausea. But there's a 0.5 milligram, 1 milligram, 2 milligram, 5 milligram, 10, and 20 milligram tabs, and then 2 milligram per cc oral solution and a 2 milligram per cc topical gel. Very wide range of dosing and frequencies can be used with this. Very similar to what we do with lorazepam for terminal restlessness. But we need to try to avoid this in patients with Parkinson's if at all possible, because the side effect can make their Parkinson's symptoms and agitation and delirium worse. Quetiapine or Seroquel comes in 25, 50, 100, 150, 200, 300, and 400 milligram tabs. This is the preferred medication in patients with agitation who have Parkinson's. It tends to be the least offensive at making the agitation worse in Parkinson's. And then Risperidone or Risperdal, 0.25, 5, 1, 2, 3, and 4 milligram tabs. That's also on our formulary and can be used for patients with psychosis and agitation. Olanzapine or Zyprexa comes in 2.5, 5, 7.5, 10, 15, and 20 milligram tabs. This doesn't get used as much. I usually use this when I want to use the oral disintegrating tabs, and those come in 5, 10, 15, and 20 milligrams. So those are just tablets that a caregiver can stick down along the buccal mucosa and they will dissolve and get absorbed that way. And then just a note about antipsychotics. In the written order, we need to try to name the specific symptom being treated whenever possible. There's a skilled nursing facility state survey requirement that the symptoms be specific, not just agitation, but are they biting, kicking, things like that, spitting out food, so that they can be quantified and the effectiveness of the medication can be tracked over time. And some of the SNFs may put a 14-day automatic stop date on antipsychotics that are PRN due to state survey regulations. As with any medication, there are side effects with these medications, and this list is primarily for the antipsychotics. All these medication classes can cause increased sedation, so you have to be aware of that when we're first starting them. But acute dystonic reaction, this is a spasming of the neck, tongue, and jaw, chorioathetoid movements, which are kind of a writhing motion, and an ipsithotonus, which is a hyperextension of the neck and back, or oculogyric crisis, which is involuntary upward eye movement. If you ever see those, just call the physician and stop the antipsychotic and possibly treat with Benadryl. Neuroleptic malignant syndrome is probably the highest risk when using antipsychotics in Parkinson's with Lewy body dementia. This is a true medical emergency. It can be severe muscle rigidity, fever, dysautonomia, meaning abnormal pulse and blood pressures, so people can become hypotensive fairly quickly, and this can be acutely fatal. So we would definitely be stopping the antipsychotics if we see anything like this. They may need benzodiazepine treatment. And then if they were in a hospital, they would use a medication called dantrolene IV, which helps reverse some of these side effects. Extrapyramidal symptoms, these are usually seen with long-term use of antipsychotics. It's also this type of chorioathetoid movement or writhing or tremors and tongue thrusting, lip smacking. Those can be treated with amantadine if someone's having an otherwise good response to the antipsychotic medication. So in conclusion, when treating the agitated patient, we're always looking for reversible causes of the agitated symptoms, and always prioritize in your evaluation of asking about psychotic symptoms, because that actually will guide therapy into a more specific realm when someone's having agitation. We're going to try non-pharmacologic options if we have that ability, changing roommates or getting them into a more quiet environment. And then just educating the family and caregivers about what this means when someone starts to have these type of symptoms. And we need to keep it simple, just like with pain medication regimens, trying to have 2 or 3 different antipsychotics or psychotropic medications in the house is just really going to confuse them and us. So we need to pick something, stick with it, and adjust up instead of switching back and forth. And then just ongoing monitoring of any medication treatments for the availability. Did it show up from the pharmacy? Are they being compliant? Actually, what dosing are they getting? And then symptom response and side effects so that we can make the necessary titrations or adjustments. Thank you.